Kim, great to welcome you.
Thank you.
I've known Kim for a long time too, not quite as long as I've known Mike. I think I knew him as a medical student, a junior doctor. Kim is a primary care physician who has worked in a number of different contexts in conventional primary care. He was the head of student health at this university, and more recently, he was medical director of Te Kāika, Māori and Pacific health provider in Dunedin, and has done a number of other exciting things. But what he's going to talk about today is some work that he's done in conjunction with, somebody was here now, where's Justine gone? Just hiding somewhere. Justine and Andrew is going to talk about the first direct research trial in Aotearoa, New Zealand. Thank you for being here, Kim.
Oh, thank you. And an addendum to a very riveting talk from Mike, thank you. And I guess the real reason why I got involved in this was I was working in an urban Indigenous-led practice here in Dunedin in Caversham, and it's 2021, and the tide of obese and sick people coming through my door was, I have to say, it was actually quite demoralising. Sort of a real sense of futility, and we had all the tools, or I thought we had all the tools to sort of help manage the situation for these people. We had a gymnasium dedicated to the patients of this practice. There was a personal trainer there who was there available to help them become more active. We had health improvement practitioners there to assist on the mental health side of people's predicaments. We had health coaches taking people for walks. You would think that everything was lining up and we were doing the very best, but the tail of the tape told otherwise. The weight, the HbA1c trending, we weren't really seeing much in the way of benefit. So where am I going? So this led to a conversation with Jim and with Andrew, and we discussed about Mike's exciting work in Glasgow and how potentially could that be brought to bear on our context in Aotearoa. So that was basically the starting point for me in 2021. We hired Natalie, who's here in the audience today, a dietitian, and put a team together and started with basically a template of the DIRECT study conducted in Glasgow, comparing usual care to a sort of a direct style of intervention, which involved 3 months of low caloric intake, 800 kilocalories a day, for 3 months, followed by a 2-month reintroduction phase, and then a normalization or stabilization phase, compared to usual care. Now, I guess I would emphasize that usual care was a little more than what usual care is in general practice in this country. I mean, this was monthly meetings with Natalie, our clinic dietitian, fortnightly initially, and I think the patients in the usual care category received way and above what would normally be available to patients in primary care. This was the characteristics of our participants: middle-aged Polynesians, a good scatter of both Māori and Pacific, quite severely affected in terms of levels of obesity. Really quite a typical sample from our practice. This describes the decline in their food intake over the first 3 months. They were at intake, they were perhaps taking over 2,000 kilocalories a day, so a dramatic change for these people. No real change in the proportion of macronutrients, apart from a decline in fat, of course, but this was not a carbohydrate-restricted diet or anything fancy in that regard. We used the Cambridge Lifestyle Intervention product, and To date, we've got some 3-month information here, which is really quite encouraging. We've seen quite significant changes in weight at the 3-month mark amongst the direct participants compared to control. Some significant declines in BMI and very encouraging reductions in systolic blood pressure, and some reduction in the amount of drugs being taken. This was probably the most elegant figure that when Andrew shared this with me recently. This describes continuous glucose monitoring data for the first 3 months. And you can see the difference between baseline in black and the direct intervention at 3 months shows that quite significant delta between the area under the curve in terms of blood sugar over the course of a day. And obviously a less distinct change, but some difference with the usual care group. Having my thoughts, having sort of participated in this trial and having a dietitian on site at the clinic who I could work with as a sort of a partner in crime, I'd have to say it's been one of the highlights of my career, having someone to actually problem solve and share the sort of clinical burden working with people with obesity and type 2 diabetes. And Natalie was a very able and skilled partner in that work. I think the induction phase of DIRECT could be likened to, I don't know if this is an appropriate analogy, but could be likened to people being induced into chemotherapy for cancer. I think there was a sort of a similar sort of feeling in terms of the challenge. These people, they get taken off their medicines. They need to adhere to this completely alien and new diet. I think there's definitely a feeling of they were doing something special. I was concerned that perhaps the shock will be too great for these patients, but I think there were other reasons for non-continuation in the program. We had about a 40% dropout rate at 3 months. And I think the factors which led to people dropping out were not perhaps the Spartan nature of the direct intervention, but perhaps other things going on in their lives. And certainly higher BMI predicted dropout in terms of participants in our study. The patients on the whole, those who didn't drop out, definitely found the intervention easier with time. And in essence, it was actually a very acceptable intervention amongst the people that persisted. I wasn't really prepared for how dependent or how attached people would become to the direct intervention. It was definitely a real task to sort of extract people, and I think, Mike, you talked about this in your speech earlier about how difficult it was for people to sort of remove themselves from the direct intervention. I think much was made about cultural perspectives and how that would affect people's interaction with direct. I felt like the key factor seemed to be like a personal commitment to engage in the intervention. And I think, as with any other population, the cultural background could be helpful or it could be a hindrance. So Natalie was very skilled at working with the whānau, with the extended family and those participants. And I think that really made the difference for us. So the final data is being accumulated now. I think next month will be the wrap-up of the study. I think we've found a reasonably effective and approachable therapy as DIRECT was found in Glasgow as well. And having the services of an on-site dietitian really made the difference. I think next steps involve perhaps comparing DiRECT with GLP-1 agonist as a potential. I think Andrew's sort of engaged in trying to get grants for such a trial to take place. But, yeah, that's it. Thank you.